Good afternoon, Professor Bear. It's our pleasure to be here in Egypt, and I think this is not the first time. So I'd like to know your experience about many topics. Let's go towards the frontal sinus itself. How you can identify the difficulties before you are doing your surgery over the frontal sinus endoscopically. What you are looking for exactly in the question other way. What you are looking for in the CTs before you are doing your surgery over the frontal sinus.
Thank you very much, Dr. Ragab. It's a great pleasure to be back to Egypt and to be back to Cairo in this specific meeting where it's the third time I am involved. For sure, frontal sinus surgery is the most difficult in the learning curve of the endoscopic transnasal surgery for sinonasal diseases. And to be familiar with frontal sinus and the access to the frontal sinus, you have to understand the complexity of the anatomy of this area. And to understand the complexity of the anatomy, you have to learn the anatomy by attending dissection courses in order to understand and I would say also familiarize with the complexity and variability of the structure that are making up the frontal recess. Once you have understood the complexity, which is essentially made by the variability of many structures, the upper part of the uncinate process, the Aganasi cell, the bulla ethmoidalis, the presence or not of frontal bullae, and also you have to understand the position of anterior ethmoidal artery. But to understand this, you have to be able to interpret the CT scan. And to interpret the CT scan, you must rely on high quality CT scan with all the cuts available, the different projection, axial, sagittal, and coronal. We know that the images are acquired nowadays only in the axial, and then they are reformatted, having all the different cuts in the different planes. And you have to be able to interpret these findings, but then you have to try to have a correlation between what you have seen before surgery and what you are going to find intraoperative, because you should never be missed. Of course, you can use navigation system for getting oriented or to control that you are on the safe way to the frontal. But the main point is the understanding of the anatomy, of the specific anatomy of the specific patient. So you have to look for Aganasi. Is Aganasi there? In most subjects, Aganasi is there, but is more or less pneumatized. You have to understand how is the insertion of the superior part of the uncinate process, because mostly the drainage of the frontal sinus is medial to the uncinate process, more rarely against the orbit, so lateral. And this is important because by following the structures, you are performing a safe dissection. If you are lost with a lot of blood in the surgical field, you have a very high chance to develop complications and to induce complications. And so to expose
you
the patient.
prefer while you are working from posterior anterior or just only working more anterior? I mean that intact bulla technique, that you will do flaps, or you are drilling justly like Caroline, windows, and so on. What's your opinion?
Okay, I believe that we have to discriminate, to distinguish between a naive patient, patients who never had surgery before, or patients with recurrent diseases. It can be inflammatory diseases, or it can be, for instance, even an inverted papilloma are benign tumor. And in this situation, I would prefer, in recurrent situation, to go from posteriorly to anteriorly. In naive patients, I prefer to go directly to the frontal sinus, and I like very much the so-called intact bulla approach. By keeping the bulla ethmoidalis intact and by removing completely the upper part of the uncinate process, you have the possibility to protect the anterior ethmoidal artery, because even though you are looking and judging where is located, it's preferable to have the anterior ethmoidal artery protected and to access the frontal sinus without removing the anterior ethmoidal bulla. This is something I learned along the years, but is something that maybe some other surgeons do not believe is extremely helpful. But for me, it's a good exercise, because in this way, you have to be very meticulous, you have to be very careful in your dissection, and you have really to follow the anatomy. While if you have scars anteriorly, if the frontal sinus is obscured, it's better that you have landmarks. Landmarks mean the lamina papyracea, the maxillary sinus, and then you approach the frontal sinus. Obviously, if the scar is massive and you have to resort to a draft 3 surgery, then you are going along the midline, because by going along the midline, you are overcoming the issue of the scar tissue and you are working in a safe plane.
If you lost your way while doing the frontal surgery, what you will do?
Oh, now I've seen. This is an excellent question. And so it's a question that is asked by many participants in courses. So basically, the patient should have symptoms that can be referred to frontal involvement. And for instance, to have symptoms that are due to frontal involvement, it's not necessary that you have a chronic rhinosinusitis with polyps or without polyps. But the patient can have barotraumatic events and symptoms due to the change of pressure.
Yes.
So in these specific cases, change of pressure and barotrauma, you have to modify the anatomy. So you can decide to dilate the frontal recess or the ostium by using a balloon dilation. Or differently, you have to perform a careful dissection of the lamellae, which are narrowing the flow in between the frontal sinus and the anterior ethmoid, and vice versa, the flow of air from the ethmoid to the frontal sinus. But you have to be extremely delicate and using a mucosal sparing technique, because differently, you are starting from one situation and you are ending up maybe with a situation which is even worse. For the same reason, if the patient has a chronic rhinosinusitis with or without polyps, but there is no involvement of the frontal sinus, no involvement in terms of symptomatology, then you have to ask yourself, I have to go necessarily for something more than a draft 1 or not? Necessarily, if you are not confident enough, it's better to rely only on a draft 1 in order not to cause side effects, symptoms, scarring in the ethmoidal recess.
Thank you very much.
Oh.
Yeah, thank you very much, Professor Pierre. It was a very nice conversation about the frontal sinus. So just in few words, tell the audience about your advice in such cases of frontal sinus pathology.
Understand perfectly the anatomy of the frontal sinus.
Yes.
Take your time. If you have some bleeding, put some sponge with the decongestant. Maybe ask the anesthesiology to lower the blood pressure
Yes.
in order to understand what is going on and what is the anatomy after your maneuvers. Don't go ahead if you do not understand clearly what you are doing and where you are doing, where you are acting.
Thank you very much
It was
for
my
these
pleasure.
very nice informations, and it's our pleasure to be here with us.
Thank you.
Thank you very much. Thank you.